Thank you.
Thank you, Dr. Harshal, for the opportunity, and respected judges, a very good afternoon. So I would be speaking today on an interesting case, a traumatic subluxated cataract. So this was a 26-year-old male who had come to us with history of injury with ball while playing cricket, and his vision had dropped to 6/60. As you can see that there is a very gross subluxation as well as there is a cataract, so we had to operate him. So we follow all the tenets and rules of these cases. Now you can see how the zonules have been disrupted in that entire area. It's almost a 5 to 6 clock hours. In the area of maximum subluxation, we do a peritomy and a partial thickness triangular scleral flap. We could have also done a Hoffman's pocket, but we were more comfortable with this. Now I'm planning where to do the side port incisions. So I've done a side port incision on the other side also and done a capsulorhexis. As you can see, the capsulorhexis is centered on the lens with a very good margin because we need to put in a CTR ring also. Two other side ports on either side of the partial thickness scleral flap to have the capsular hooks onto the capsulotomy edge. And now very gently and meticulously, without any fluctuations in the anterior chamber, we are taking out all the lens material through a bimanual irrigation aspiration. Filling in the chamber with viscoelastic, I am first putting in a CTR through the side port. And then as you can see, the CTR is on from the left side with a long dialer or a Sinski hook. We are supporting the edge so as to ensure that the entire CTR goes into the capsular bag. The capsular hooks are now removed, but you can see that in spite of putting just the CTR, this is not enough because we know that this is a very large subluxation. So we will be now buttressing it with a CTS. So this is now the 90 proline suture is now already put through the hole of the eyelet of the CTS. It is put in through the main incision in such a way that the eyelet comes at the site of the maximum subluxation. Now the eyelet is always anterior and it comes anterior to the anterior capsular margin. We are using the 90 proline because Gore-Tex was not available at that point of time. And now through a bent 26 gauge needle which goes in through the partial thickness scleral flap, we are using the double-ended 90 proline suture through the main incision and railroading it through the 26 gauge bent needle. So this is the first one which has come out. For the second suture, we are repeating the same procedure, railroading the 90 proline needle.
Can you pause the video, Dr. Anagha? Once?
Yes.
Yeah. So I'll just like to ask Dr. Gaurav, Dr. Ramamurthy, that what is your preferred device here to take care of this subluxation? Sioni CTR or a CTR plus CTS like this?
So
and yeah.
I would actually do exactly what she's done. I would do a CTR plus a CTS. The order may change. Sometimes I would just during the surgery support the bag with a CTS and anchor it to one side so that I can operate and get
instead of using capsular hooks.
Sometimes, yeah. So it all depends, and I actually like to use capsular hooks, but sometimes the timing of putting the CTR can be variable. Sometimes I'll use the CTS first to fixate, and then I might just put the CTR later. But other times, when the bag is collapsing and everything, then I might just put the CTR first and then use the CTS to fixate the bag later on. It all depends on during surgery how it's going. But capsular hooks do remain, but I prefer to use the MST capsular hooks, which are much wider because they hold. Then you can delay your CTR insertion if you're putting the MST ones. With these kind of hooks, you have to kind of go earlier with the ring. I don't know what to tell.
I think a CTR, a CTS is not even required in this case. In the sense that, it's though the subluxation is quite significant, it's a traumatic cataract where the subluxation are progressive. If it was Marfan's, if it was pseudo-exfoliation, I would have definitely preferred that. But as you can see, once you put the CTR in itself, the bag seems to be quite stable. And once you put the intraocular lens with the haptic submitting in that area, quite often it
but there was a gap. There was a significant gap. So once I take the suture, you can see how it comes to the...
so decentered, then it'll move. I mean, it may not subluxate further, but
I have had situations like this. It's of course CTR I've almost given up completely because CTS is so much easier to handle with a CTR plus a CTS. But many traumatic cataracts where the further zonular dialysis is not there, I manage with just a CTR and an intraocular lens also.
Namrata ma'am, Hoffman pocket or the scleral flap like this? What would you think will be a?
I would go for Hoffman pocket, and I would use a Sioni rather than a CTR and CTS in this.
In one go, you take care of all two things. Yeah. Okay. Fine. I think let's move ahead. Yes. Yes.
So now we are pulling in the sutures, and you can see now how the entire capsular bag, we can see how the zonules on the top are present, but inferiorly they are absent, but now it's the entire bag will approximate very well, and we can now stretch the bag completely. So the idea was that the entire bag opens up completely so that later on, because of capsular contraction, there should be no phimosis or decentration of the length. The patient is a young boy, so we didn't want to take any chances. And then we are putting in a 3-piece lens. So here the eyelet comes on top of the anterior capsular margin and the 3-piece lens goes in, and it's well centered.
Anagha, Dr. Anagha, again here, maybe from all the panelists, that would you prefer once you put in a CTR and a CTS
Yeah, we
and
could have
everything?
put in a single piece.
I know you can, but I'm just trying to kind of create a discussion on
Right,
one or the other, because getting a 3-piece into the bag and the injection and everything is more unpredictable with a bag which is already unstable, and since you've already put in a CTR and CTS, so the idea of putting the 3 pieces that suppose in future it dislocates, you can still fixate it.
Yeah.
But if you already have a CTR in place, then it will serve as an anchor point anywhere and you're anchoring with the CTS. So in such situations, I actually prefer to put a in the bag single piece lens which will open up in the bag, something like a 9x or something which you can do, don't have to do wound assisted injection, and you just inject the bag very, very predictably.
So for progressive zonulopathy in like Marfan's, you can use 3-piece, but for traumatic, as Dr. Gaurav said, you can safely use single piece in capsular bag.
And then we used glue to for the partial thickness scleral flap and the conjunctival flap.
Another recommendation is that these 3-piece lenses, when you're using, you can put them in the sulcus.
Yes,
with
and
the
then
haptics in the sulcus and just create an optic capture.
Yes.
That
So
also stabilizes the bag very well.
post-operatively, the patient did very well with a vision of 6/9 and a very well-centered lens.
Yeah.
Thank you.
So I think that case was very well managed. Rishi, your comment? Anybody else?
I think all the comments that I could have said have already been said. It's beautifully managed.
Yeah.
Very little to change.
Thank you so
Thank
much.
you so